to our Japanese friends and colleagues. It's really a deep pleasure to have you all here today. And I will thank later all the people who really helped organizing this, but it's really a great pleasure to have our researcher, our university, our institution of research, INSERM, really collaborating with our Japanese friends. Professor Shiro will start by introducing the session, Professor Ishihara, and then I will take over. Shiro, it's for you.
Okay, my name is Shiro Ishihara from Japan. I'm working the Nippon Medical School Musashi Hospital. This is a university hospital. And I'm really happy to have this meeting today. First, I rechecked my email and I found out that this meeting has been planned for 1.5 years. And about a year ago, Miss Fatima joined, and right after that, I joined. And long time has needed to have this meeting because of planning, scheduling, and rescheduling again and again. And so, and I think COVID-19 has great impact on this delay, I think. But I'm really glad that I could be together with you by using this conference, but I mean Zoom. I think the purpose of this meeting is to exchange ideas between France and Japan and to find a new platform to launch new promising study concerning kidney and heart, I think. And thank you so much for Ms. Fatima. She arranged everything for this meeting. So, okay, this is my start. Thank you so much.
Thank you very much. Now we will ask Professor Hugues Boiteau from INSERM. He's leading the international relationship of INSERM, who also was very instrumental and helpful inside INSERM to allow us to do this great meeting. Mr. Boiteau, please.
Thank you very much. Dear professors, dear Japanese and French colleagues, as policy officer for cooperation with Asia at the International Relations Department of INSERM in Paris, I am delighted to participate in this opening of the seminar since our team, as Professor Mabasa has stressed on the instant, we have provided some support to his team to set up this event. First of all, I would like to recall 3 key figures which illustrate the major place that Japan occupies in INSERM's panorama of international cooperation for science and research. First, Japan is a long-standing partner of INSERM. Japan is the 14th global partner for co-publications out of a total of more than 100 countries, which occupies also the 2nd place in Asia with nearly 400 declared co-publications, and this tendency is on the rise. Second thing, in 2020, 33 Japanese researchers carried out research mobilities at INSERM, and today 120 scientific collaborations have been declared, particularly in the field of neurosciences, cancer, metabolic diseases, etc., as illustrated by the theme of this seminar, which brings us together today. Institutionally, INSERM's main partners in Japan are universities of Kyoto, Tokyo, Osaka, Tohoku, and we have 2 cooperation agreements that are active with the Japan Society for the Promotion of Science and the University of Keio. Beyond these few benchmarks and figures, I would like to stress that on a strategic level, Japan is a priority partner in INSERM's international strategy. As such, Japan is part of our first so-called Thematic Cooperation Partnership, TCP, which is a new tool devised for structuring international cooperation supported by INSERM. In addition, INSERM actively contributes to the preparation of the health component of the joint committees between France and Japan in close coordination with the Ministry of Higher Education, Research and Innovation in France, as well as to the development of the Franco-Japanese health roadmap with the coordination of the Ministry of Health and Solidarity and Ministry of Europe and Foreign Affairs. So I now wish every success to the Franco-Japanese seminar jointly carried out by the teams of Professor Alexandre Mebasa and Dr. Shiro Ishihara. Thank you for your cooperation.
Thank you so much, Mr. Boiteau. And as you mentioned, the relationship between Japan and France are very tight and increasing. And we hope that this seminar will really be instrumental to help growing more in the metabolic and cardiovascular area. It's now my pleasure to introduce Professor Catherine Chaussin. She is the Vice Dean of the Faculty of Health, and she's the Vice Dean of Research covering and taking care, and she's really the pilot of all the research done in the Faculty of Health. Thank you, Catherine.
Thank you very much, Alexandre. Welcome, dear friends. Welcome from Japan. We are very, very happy to welcome you at Université de Paris. This is a brand new university. We are not 2 years old already. And it's a big challenge to build a big university. And we have many hospitals in our university and several teams working on heart or kidney disorders. And it's really a fantastic job that Alexandre, Chantal, and Jean-Sébastien and Pierre-Louis are doing on gathering together this strength to make a big institute out of the wall for heart disorders. So we are very happy with this collaboration, because I think that today is the first real event of the cardiovascular out of the wall institute. So it's really a great pleasure to open this ceremony, and the partnership with Japan is quite an honor, and Université de Paris is very touched by this event, and we hope that this collaboration will be strengthened for all the medical, pharmacy, dental disciplines in our health faculty. So I feel very honored. I wish you a very nice day, a very nice collaboration. And I have to add that we are very happy that 2 PhD students of Université de Paris are going to come to travel to Japan to stay in our hospital and lab research. It's a great honor. So have a nice day and enjoy this very nice science. Thank you, Alexandre. Thank you to all.
Thank you, Catherine, for these nice words. And as you said, it's really great to have this workshop all together, because it comes at the moment where we have a university, one of the largest in Europe, that came out, and this Institute of Cardiovascular Sciences that just also was born a few days ago, and putting together all the major cardiovascular and metabolic and kidney teams in Paris region. Now it's my pleasure to ask Professor Chantal Boulanger and Professor Kent Toy to take over.
Hello, good morning, everybody. Maybe I'd like to introduce myself first. My name is Chantal Boulanger. I'm the director of the Paris Cardiovascular Research Center, and I'm also a member of the Université de Paris Institute for Cardiovascular Sciences. And I'm very pleased to share this session with Dr. Professor Kent Toy. Professor, would you mind introducing yourself?
Oh. Oops.
Yeah, we hear you. Would you
Okay,
mind
okay.
introducing
Yeah.
yourself?
Thank you very much for inviting me in this great conference also. My name is Ken Doi. I'm working at the University of Tokyo, and I'm now working at the ICU of this hospital and taking care of COVID-19 patients currently. That's not so bad. So basically, my background in nephrology and critical care medicine. That's why my chief, target of my research is acute kidney injury. So anyway, I would like to enjoy this session together with Professor Chantal. Okay, so shall we start?
Yes.
Okay,
Well,
so who's gonna introduce the first speaker, you or me?
maybe I would introduce the first speaker who is from Japan, and then you would go on, and I would pick up with the third, and so on.
Okay, yeah, all right.
Good for you. All right. So it's my pleasure to introduce Dr. Atsuko Ikemori, who will present her talk on how heart failure is damaging the kidney.
Okay, I'll start.
Thank you.
Can you see the slides?
Yes, it's good.
Hello, everyone. I'm Chairman. My name is Atsuko Ikemori. It's my great pleasure to have opportunity to present. I'm belonging to Anatomy, St. Mariana University School of Medicine in Japan. My specialty is nephrology and anatomy. I have no relevant financial relationship disclosed. At first, I'm introducing our university. It is placed in Kanagawa-shi on Kanagawa Prefecture in Japan. Apart from other medical schools in Japan, our university was focused on the basis of Christian love for humanity. Therefore, there are one father and two churches in the university and hospital. I have been working here about 20 years. I'm not Christian, but I have always been taught how to live for human specialty scientist and doctor by what father talks in some ceremonies, such as Thanksgiving for experimental animals and memorial service for Kawada in anatomy. When you come to Kawasaki, please drop in and see me. Now, I would like to start the subject of a relationship between heart and kidney. Unfortunately, I have not investigated about cardiorenal syndrome, but I summarized some recent reviews. While heart provides blood and oxygen to all the organs, kidney regulates circulating volume. Both heart and kidney play important roles in homeostasis of systemic circulation. Dysfunction in one organ loads overwork on the other organ and injure them. When heart failure is induced, kidney disease occurs. On the contrary, renal failure causes cardiovascular disease. Eventually, both organ failures are accelerated by the bidirectional heart-kidney interaction. Coexistence of cardiovascular and kidney disease widely become known, leading to a formula definition of cardiorenal syndrome in 2004. Cardiorenal syndrome is abbreviated to CRS. In 2008, recognized a wider clinical spectrum that many may represent cardiorenal dysregulation. CRS was phenotyped into two major groups, cardiorenal and renocardiac syndrome. Furthermore, CRS was grouped into 5 subtypes based on disease acuity, and sequential organ involvement. This classification is useful for grasping of morbid state, diagnosis, and selection of treatment of cardiorenal dysregulation. In 5 subtypes, type 1 and type 2, heart failure resulting in kidney disease. Type 3 and type 4 are renal cardiac syndrome, kidney disease resulting in heart failure. Finally, type 5, which is called a secondary CRS, is called development of chronic kidney disease and failure due to a systemic illness, sepsis, DM, S3, and amyloidosis. The section is to reveal why heart failure causes kidney disease in CRS type 1 and type 2. CRS type 1 is acute failure induces acute kidney disease. In this type, between 27 and 40% of patients hospitalized for acute heart failure was reported to develop acute kidney disease, AKI. Why does acute heart failure induce acute kidney disease? In severe decompensated heart failure with decrease in systolic blood pressure less than 80 mmHg, renal hypoperfusion is induced. Renal hypoperfusion activates sympathetic nervous and renal angiotensin aldosterone system, RAS, and release arginine vasopressin, and they cause preglomerular vasoconstriction, leading to decrease in glomerular filtration rate. As a result, AKI occurs. Furthermore, non-hemodynamic factors such as inflammatory cytokine release, oxidative stress, and endothelial dysfunction contribute to acceleration of hemodynamic disorder. On the other hand, incidence of AKI is found in heart failure with preserved ejection fraction. CRS type 1 may not be induced by renal hypoperfusion alone. Recently, renal venous hypertension caused by venous congestion with heart failure is noticed as a mechanism of CRS. Venous congestion is diagnosed by increased right arterial pressure and central venous pressure. In severe heart failure, visceral edema and ascites increase intra-abdominal pressure and contribute to venous congestion and renal venous hypertension. GFR is determined by the pressure gradient between glomerular capillaries and the Bowman space according to the next formula. Therefore, reduction of GFR occurs when capillary hydrostatic pressure is reduced by low renal perfusion and hypotension. And Bowman hydrostatic pressure is increased by renal congestion. Why does renal venous hypertension lead to decrease in glomerular filtration rate and onset of AKI? This point is not fully elucidated. Renal venous hypertension activates sympathetic nervous system and RAS and increase glomerular pressure mainly in efferent arteriole. As a result, transglomerular pressure gradient decrease, leading to decrease in glomerular filtration pressure, resulting in decreased glomerular filtration rate and onset of AKI. Furthermore, as kidney has a stiff renal capsule, renal venous hypertension causes renal parenchymal congestion, leading to increased renal interstitial, intertubular, and Bowman hydrostatic pressure. That results in decrease in glomerular filtration pressure and AKI. Onset of AKI. When there are visceral edema on ascites, intra-abdominal pressure increase and contributes to venous congestion and renal venous hypertension. Renal venous hypertension causes elevated intra-abdominal pressure, leading to reduction of renal blood flow, resulting in renal hypoxia and renal dysfunction. Next, CRS type 2 is chronic heart failure, resulting in chronic kidney disease, CKD. Chronic heart disease and the CKD frequently coexist, and there are often difficult cases to distinguish which disease came first. Between 45 and 64% of patients with chronic heart failure have evidence of CKD. Some CRS type 2 patients may transition to CRS type 1 at various time points. Heart disease reduces cardiac output, which activates sympathetic nervous system and decreases renal blood flow. They activate RAS and decrease in renal blood flow induce renal hypoxia. Activation of RAS and renal hypoxia are related to onset of kidney disease. Right ventricular dysfunction or reduction of cardiac output induce venous hypertension, leading to renal venous hypertension. Renal venous hypertension causes renal hypoxia and kidney disease. Finally, inflammatory cytokine release and oxidative stress in heart disease affect on kidney disease. Professor Mori and Professor Ito proposed a mechanism of renal injury on renal congestion by ligation of inferior vena cava between right and left renal vein. The elevation of left renal venous pressure increases lumen expansion pressure of vasa-recta, leading to detachment of pericyte. In scanning electron microscopy, pericyte detachment was observed in the vasa-recta, in the descending vasa-recta. The detachment induced pericyte myofibroblast transition and progressed renal fibrosis. They indicated that pericyte myofibroblast transition by renal venous hypertension was related to progression of kidney disease. I have told the mechanism by which acute or chronic heart dysfunction induces renal function until now. Apart from that, lastly, I will introduce the findings that the heart and kidney function cooperatively in generating an adaptive response to cardiac abnormalities. Professor Nagai and Professor Manabe revealed the presence of heart-brain-kidney network controlled by neural and immunological signals using a collecting duct cell-specific KLF5 deficiency mice. KLF is a member of Krupp-like factor family and plays a role of recruiting macrophages by secreting of S100A8 and S100A9 and promoting their differential into inflammatory macrophages. Therefore, the deficiency of KLF5 in collecting duct did not induce interstitial inflammation in kidney disease. They made transverse aortic constriction. Pressure overload to the left ventricle activates cardiac afferent nerve and sympathetic nerves that innervate the kidneys by brain. Thereby, renal collecting ducts are activated by adrenergic beta-2 receptor, and activation of KLF5 in collecting duct is induced. The activation causes selection of TNF-alpha from inflammatory macrophages, and the TNF-alpha acts on endothelial cells, which released colony-stimulating factor from the endothelial cells to systemic circulation. The cytokine affected on cardiac macrophages, which release amphiglin. Amphiglin-induced cardiac hypertrophy as a myocardial adaptive response to cardiac pressure overload and contributes to retention of cardiac function. On the other hand, KLF5 knockout mice did not show such adaptive response, and many knockout mice died. Thus, these results show that dynamic interplay between the heart, brain, and kidneys due to sympathetic nervous system and macrophages was necessary for adaptation to cardiac stress. In conclusion, there are various complicated or unknown mechanisms between heart failure and kidney disease. Although renal function in heart failure is clearly associated with poor outcome, further study is needed to continue to clarify the pathophysiology of CRS. Thank you, attention.
Thank you very much, Dr. Ikemori. We have time for a few quick questions so we don't delay the next speaker. Are there questions from the audience and from the floor? I don't see any hands raised. Maybe I could start with a quick question. You gave us a very nice overview of the different cardiorenal syndromes and the different mechanisms involved. Well, could you elaborate also a little bit on the delay, the time it takes for signal from the heart to have consequences on renal function and vice versa?
Sorry, one more, please. Once more, please. I can't catch your question.
Okay.
Sorry.
The time it takes for the heart dysfunction to have a consequence on the renal function. Does it take days? Does it take minutes? Does it take months, years?
Months, year.
No. Yeah, she's asking you how about the duration, length of time? It's gonna take several months or just hours or years?
Is this experiment?
Yeah, for example.
Acute kidney disease. In acute kidney disease, renal function is observed for hours or days.
Okay.
And chronic kidney disease is 3 months or 6 months.
All right.
Is it okay?
Yeah, it's okay. Are there other questions from from the floor or from the different participants?
Dr. Saraux, please.
Yes, yes. Good day, everybody. I'm delighted to attend this meeting. So I have a question regarding this interesting work as you presented, where parasite detachment in the kidney medulla, yes, on slide 19, may be involved in kidney fibrosis and damage. So do you think that that might occur in different conditions, such as not only, I mean, that may happen when there is venous hypertension and renal congestion, but that could be that could happen in different circumstances, such as chronic heart failure or AKI as well. So what do you think? Are there specific contexts where such work has been replicated?
In this manuscript, I read chronic phase of renal tissue after renal venous hypertension model.
Yeah, but this is interesting because this might happen in various clinical and experimental setting. I think it's a very interesting finding. Since also there are other works that suggest that parasites become the myofibroblast in the kidney in chronic models. Thank you very much.
Parasite myofibroblast transition.
Yes. This might be something happening in various conditions that should we be worth to investigate, I think.
In clinical situation, parasite myofibroblast transition have not been demonstrated, I think. So I don't know how what happened in clinical situation. Parasite myofibroblast transition maybe occurred.
Yeah. Okay.
Maybe occur.
Yes, we should look in kidney biopsies from patients and other experimental models.
It's difficult to, it's difficult to establish model of renal venous hypertension.
You're right, but if there is chronic heart failure, that may also lead to venous hypertension and promote such events chronically.
In clinical situation, renal biopsy is performed. Be performed. I could catch the observation.
Yeah. Okay.
Okay, thank you so much, Dr. Ikemori. I think it's time to move on to the next speaker. And I'll share to Dr. Doi.
All right, let me introduce the second person, Professor François Depret. The title of presentation is The Role of Galectin-3 in Kidney Failure-Related Heart Dysfunction. Okay, please start.
Hey, do you see my presentation?
Yes.
Okay,
yes, it's
perfect.
Perfect.
Yes, thank you. Okay, so thank you for the introduction. My name is François Depret. I'm an anesthesiologist and intensivist in the Department of Anesthesiology, Critical Care and Perioperative Medicine in Saint Louis Hospital. And I work in Alexandre Mebaza's team in clinics and in research. So I will talk to you about the role of galectin-3 in kidney failure-related heart dysfunction. So before I start, here are my conflict of interest, and none of them are related with this presentation. So in introduction, Mathieu Legrand and Patrick Rossignol recently summarized the cardiac consequences of acute kidney injury in a very elegant review published last year in New England Journal of Medicine. And in this review, they discussed the current understanding of the cardiovascular consequences of acute kidney injury, also called type 3 cardiorenal syndrome. To illustrate the association between acute kidney injury and heart failure, I will present you this study published in CGA SEN in 2018, in which the authors matched more than 30,000 patients with AKI during hospitalization, with more than 150,000 controls without AKI. And they look at the prognosis at 1 year. And during the first year after discharge, the risk of hospitalization for heart failure was increased by 44% in the group with acute kidney injury as compared with the group that did not have kidney injury, suggesting a link between acute kidney injury and heart failure. The pathophysiological pathways by which AKI can promote the development of heart failure are multiple, and most of them are common between the development of chronic kidney disease and chronic heart failure. You have systemic inflammation, immune cell infiltration, of course, renin-angiotensin aldosterone system activation, renal sympathetic nervous system activation, etc., etc. Two important pathways whose inhibition is now part of the treatment of heart failure with reduced ejection fraction are the renin-angiotensin aldosterone system inhibition and the neprilysin system inhibition with Entresto, which is an association of valsartan and salcubitril. The pathway I will present you today is the galactin-3 pathway, which maybe is a bit less known. So galactin-3 is a soluble protein from the lectin family with a molecular weight of about 30 kilodalton and a particular affinity for the polyactosamine structure. Galactin-3 is expressed only in mammals and has two parts, a catalytic C-terminal domain for carbohydrate recognition and the N-terminal domain for pentamerization. It is expressed in many cells, but not in cardiomyocytes, and its expression increases cells proliferation, collagen production, survival, and migration, and is involved in the fibrosis process. In 2019, Mathilde Prudhomme, who did her PhD in the lab, published in a JACC BTS a very, very nice study. And in this study, in mice with acute kidney injury, she found that galactin-3 induced cardiac inflammation, cardiac fibrosis, and cardiac failure. And when she inhibited GAL3 either using knockout GAL3 mice or modified citrus pectin, which is a GAL3 inhibitor, she restored a normal heart phenotype. In the same study, she looked at critically patient cohort, and she looked at the relationship between galactin-3 plasmatic level and AKI severity and cardiac injury biomarkers after AKI. And I will show you the result of this study, but before I will say a few words about this cohort, the FROG ICU cohort, because most of the results I will show you after are from this cohort. So the FROG ICU cohort is a prospective observational cohort, multi-center, with about 20 centers in France. And the inclusion criteria were adult patients with invasive mechanical ventilation support and or vasoactive agent for more than 24 hours. In this cohort, the ICU mortality was 22%, and for ICU survivors, the 1 year mortality was 21%. And the objective of this cohort was to assess the factors associated with 1 year mortality after ICU discharge. So if we come back at Mathilde's study, she looked at the galactin-3 level at discharge and the relationship with the severity of AKI during hospitalization. And she observed that there were an increase of galactin-3 depending of the AKI stage. So this could suggest that galactin-3 is a marker of kidney function and maybe not a marker of severity or prognosis. Then she looked at the association between acute kidney injury and cardiac biomarkers at discharge, and we see here that also again galactin-3 is higher in a patient who who had an AKI during hospitalization, but also we can see an increase of cardiac damage biomarker and inflammatory biomarker with ELCs, which were higher in AKI patient compared to non-AKI, suggesting a link between acute kidney injury, cardiac injury, and inflammation, which maybe is the link with a worse outcome in patient with AKI. In frog, we recently looked at the correlation between admission eGFR and admission galactintra, and we observe a good negative correlation between these two biomarkers, suggesting that, as I said before, GALTRA could be a good biomarker of glomerular function, and therefore we can ask if GALTRA is just a kidney function biomarker, kidney function that we know being associated with poor long-term cardiovascular outcome, or if GALTRA is independently associated with poor long-term outcome. To try to give some answer to this question, there is this study published in the JACC in 2018, and in this study they included more than 2,000 patients, offspring from the Framingham Heart Study cohort. And to this patient, they make a dosage of galactintra at 2 time points, one time point between 1995 and 1998, and the second time point between 2005 and 2008. And they look at the long-term outcome of this patient, depending of the level of galactintra at the first time point and at the second time point. And what they observed is that patient who is high galactintra at baseline, that stay high, or patient with low galactintra at baseline and that becomes high at the second time point, have a worse outcome than patient with a high galactintra at baseline that becomes low, or low that stays low. And it was the same for heart failure, cardiovascular disease, and mortality. So this study suggests that there is a real link between high galactin 3 level and cardiovascular outcome. And then they performed a multivariate analysis adjusted on many factors, but on eGFR. And they observed that even adjusted on eGFR in multivariable analysis, baseline galactintra and the change in galactintra over during time was independently associated with outcome for heart failure, cardiovascular disease, and mortality. So I think with this study we can say that galactintra is associated with a worse cardiovascular outcome independently of the kidney function. So we came back to the frog ICU cohort to see if we observe similar results. And here are the galactintra level at discharge for the ICU survivors, and the level between survivors and non-survivors at 1 year. And we can see that non-survivors at 1 year have a higher galactintra plasmatic level at discharge. So it goes in the same way that the study we saw before. Then we wanted to look at the relationship between galactintra level at discharge and AKI during ICU stay. We defined positive galactintra in patients who had a galactintra value above the median. And we can see here again that we know that AKI is associated with worse outcome. So it's not a surprise that patients with AKI here on the Kaplan-Meier curve have a worse outcome at 1 year. But we can see that galactintra allows to discriminate among patients in the population with AKI, a population with a worse outcome, patient with AKI and positive galactintra having a worse outcome than patient with AKI and a negative galactintra. And it's the same in patient, and if even stronger in patient without AKI. Here, the patient without AKI with a positive galactintra have definitely a worse outcome than patient without AKI and a negative galactintra. Suggesting again that galactintra has a link with outcome independently of the occurrence of acute kidney injury. Then we also performed a multivariate analysis to see if we observe the the same results, and even after adjustments on many factors, the factors who have been found to be associated with 1 year prognosis, but also with serum creatinine at discharge, we can see that galectin-3 was still associated with a worse outcome. Here it's a major adverse kidney event at 3 months after discharge, and mortality at 1 year. And GAL3 stays associated with a worse outcome independently of the serum creatinine at discharge. So to conclude, we can say that galectin-3 is probably a good marker of glomerular function, but not only a marker of glomerular function, because we can see that it's associated with short and long-term prognosis in AKI patients, but also in non-AKI patients. And maybe galectin-3 could allow screening for future RCT, since treatment exists against galectin-3, so it should be tested in patients with a high galectin-3, and why not at after ICU discharge, or after any critical condition with a kidney injury. Thank you for your attention.
Thank you very much. Very wonderful talk regarding galectin-3 and the outcome prediction of the very severe patient treated in ICU. So is there any question from the audience? Jean, oh yeah, two guys are what to say, raising their hands. So please start with Jane Sebastian.
Yeah, so thank you for the very interesting talk. I have just a short question. So do you have any idea about the main cellular source of galectin-3 in these settings?
It's in human, it's not clear. What Mathilde showed, I didn't went into details of this thesis. It was a big work, but what she showed, she used a bone marrow transplantation to try to assess the origin of galectin-3 in these mechanisms, and it appears to comes from cells derived from bone marrow. She grafted knockout galectin-3 mice with a bone marrow of wild type and vice versa, and in wild type mice grafted with a bone marrow knockout mice, the mice did not develop heart failure after acute kidney injury, and she did not observe heart inflammation and fibrosis, and vice versa when she did in the other. So in mice, at least it appears to come from cells derived from bone marrow, maybe macrophage, but in human it's not sure. And many cells produce the galectin-3, and there is an obvious link between EGFR and galectin-3. So one part of the increase of galectin-3, I believe it's due to the decrease of renal excretion of galectin-3.
Thank you.
Okay, thank you. Let's move on to the second question. Professor Yugo Shibagaki, please.
Hi, my name is Yugo Shibagaki, and thank you very much for your very nice presentation. It's very interesting. My question is that, is it possible that the event of the heart failure post-AKI has something to do with the ongoing kidney tubular dysfunction, not the glomerular dysfunction in AKI-CKD connection, rather than the cardiac injury during AKI? I mean, in other words, is galectin-3 associated future kidney dysfunction rather than the cardiac injury?
Possibly, galectin-3 is involved in fibrosis mechanisms, not only in heart failure, in many organs, and of course it can be involved in CKD development, which is linked with heart failure development.
Yes.
So it's
and do you have any direct evidence that the cardiac injury is the cause of the heart failure after the AKI?
In human, no, but in Mathilde thesis with the mice study, Yes, because what she did acute kidney
Right.
injury,
Mhm.
and she observed fibrosis and heart failure that was restored when she inhibited galectin either using knockout or MCP.
Okay, thank you very much.
This is a very tough question. Yeah, I agree. So then, please, quick last question from Professor Ishihara, please.
Thank you so much for a great presentation. You shows the slide Flamingo Offsprings study. You showed that the first period and second period, there is a difference between. There is no difference between high and high and low and high. And the other one is high and low and low and low is identical. For my opinion, I think the high and high is very bad prognosis, but low and high is also bad, and the prognosis is identical, high and high. So it means the 1 point measurement of galectin-3 is not enough to for the prognosis. What do you think? We have to check severe galectin-3 or something, maybe other biomarkers as well. I don't know.
Yeah, but I mean, yeah, if it's low, of course, 1 point is not enough, but we can see that when it's high, and it's what we observed also in the frog ICU cohort, we just have 1 time point at ICU discharge. And when it's high, the patient have a worse outcome at 1 year. It's the same in the Framingham offspring cohort, and that we don't know in the Framingham cohort. It's when it becomes, because there is 10 years between the 2 time points, and it's when it becomes high, and what happens in these 10 years of time to explain what it becomes high and how many years it stays high.
Yeah, thank you.
Okay, thank you very much for the very good questions regarding galectin-3. So we need to move on to the next presentation. Okay.
All right, the next presentation will be given by Dr. Shiro Ishihara, and it's about health fatty acid binding protein.
Okay. Can you see this slide?
Yes.
Yes. Yes.
Okay. Oh, sorry. No. Okay. I would like to present FABP, fatty acid binding protein. I have no conflict of interest in this slide. Acute kidney injury is common in hospitals, adults, and children, and associated with serious complications and high health cost cares. Traditionally, 2 functional biomarkers such as serum creatinine and urine output are used to define AKI, acute kidney injury. Meta-analysis of 154 studies that defined AKI according to the 2012 Kidney Disease Improving Global Outcomes, KDIGO classification, compares data of more than 3 million people from mostly north of high-income countries, and reported community-acquired AKI in 8.3% of ambulatory patients, and in 20 to 31.7% of patients at various levels of in-hospital care. And the average pooled mortality rate was 23%, but reached to 49.4% in those requiring kidney replacement therapy. These two biomarkers are very useful to detect acute kidney injury, and these biomarkers are not expensive, and we can get all over the world, but these biomarkers are limited by delayed changes following kidney injury and have low sensitivity and specificity. So several novel biomarkers have been shown to detect acute kidney injury area and are more sensitive than serum creatinines. And many experts recommended the use of unique framework of the combined use of functional and also damage biomarkers. This framework could provide a potent, provide a potent tool and to enable clinicians to effectively utilize biomarkers in acute kidney injury. For instance, a physician can identify patients who manifest kidney damage without any functional change. If we can find this kind of patients before starting treatments, we can modify nephrotoxic agents such as aminoglycosides and vancomycin and so forth. And the other scenarios is that if patients have no kidney damage and no functional changes, we can identify these patients have no AKI, and so maybe we don't have to change the dose of the drug. Over the past few years, the biomarker yields for acute kidney injury has rapidly expanded with the identification of different molecules emanating from the injured kidney or reflecting altered kidney functions. These molecules have ranged from constitutive proteins released by the damaged kidney to molecules upregulated in response to injury or non-renal tissue products and filtered, reabsorbed, or secreted by the kidney. And there are many various type of molecules to identify kidney injury or kidney damage. Right now, we are focusing liver fatty acid binding protein here. And liver fatty acid binding protein FABP is a 14 kilodalton protein expressed in proximal tube epithelial cells. This endogenous antioxidant promotes fatty acid free fatty acid metabolism by binding long-chain fatty acid oxidation products. And the LFABP gene is responsive to hypoxic stress, which occurs in the setting of kidney ischemia perfusion injury. As a consequence, urinary excretion of LFABP reflects the stress of proximal tube epithelial cells correlating with the severity of ischemic tubular injury. And as you can see, this LFABP is a damage marker here, and also role in practice is diagnostic of AKI. There are two unmet needs. This is my proposal, and whether a change in serum creatinine or oliguria without change of LFABP is damage biomarkers is associated with kidney function, kidney and patient outcomes, and also whether elevation in FABP without any changes in serum creatinine oliguria is associated with worse kidney and patient outcomes. I think Garkin 3, he shows the same messages, I think. And this is Frog ICU. He presented the Frog ICU rate before, so I will start talk about the results. 2087 patients are included, and AKI has happened 44%. Number is 855. And I think FABP T1 and T2 represents the admission and addition respectively. Actually, I have this slide yesterday night, so I don't have any detail about this information, but I think the T1 is admission and T2 is discharge. And number itself is T1 is 3.1 and T2 11.2. And this is LFABP admission and kidney outcomes. left side is the patients who have AKI. The number of body of FABP is higher compared to the patients who don't have any acute kidney injury. And also FABP T1 at admission, I think, is increasing according to the stage of the KD stage classification. And there are big differences between these 4 points. And it is also T1 admission, FABP admission. This is mortality of 13 days. There are big differences between these 4 totals. The higher the LFABP at admission, the worse the prognosis is. But the AUC is 62.6, and so it's not so high. But still, there is big difference between these 4 groups. This is T2 LFABP. I think this is at discharge. This represents mortality 1 year. Unfortunately, there is no difference between these 4 totals. P-value is 0.05. And also this is AUC is not so high. This is my summary. LFABP is promised biomarker to identify the risk of acute kidney injuries, but data is not enough yet. And we will get the result from ICU soon, and we will present you all later. Thank you so much for your attention.
Thank you very much, Dr. Ishihara, for the wonderful presentation on fatty acid binding protein. I have a quick question, if I may start. You mentioned it's an intracellular lipid binding chaperone. When you do measure it in circulating blood or in plasma, do you think it's a sign of cellular injury, or is it part of a normal cycling of the protein?
Oh, thank you so much for your question. Actually, in Japan, we have a tool to measure blood LFABP, but we don't have any precise detailed data. But I think the normal metabolisms, there is, I think, LFABP is present in blood. So, but if patients have damage or inflammation, or the level of LFABP, like blood and urine, I think it will increase. So, yeah.
But do you think there would be changes in LFABP excretion by the kidneys during AKI, or that would contribute to the increased level? Do you see what I'm trying to come to?
Yeah, you mean during AKI, the production from the kidney will increase?
Yeah.
Your question? Yeah. It is said that that this is tubular markers, damage markers. So if patients have damaged kidney, the production, not the production, but production itself will increase. Yeah, LFABP. Yeah.
And have you localized the production of these LFABP yet?
Yeah, I think,
what cell type, the cell type?
A subtype?
Hmm.
Yeah, there are different subtypes like LFABP and I.
No, she's asking you the cell type of the kidney.
Yeah.
I'm sorry.
A cell type.
Yeah, cell type. Sorry.
Not a subtype?
No.
Cellular type. What cell produces?
I'm sorry, I don't have any.
I know the answer. This
yeah.
molecule is mostly expressed in the tubular epithelial cells located in the proximal tubules.
All right.
So,
okay.
Thank you so
I
much.
see a few hands raised, but I don't know if they are old hands or hands for questions to Dr. Ishihara.
No, I have a question, Chantal.
Oh, sure. Go ahead.
Yeah, so thank you for the interesting talk. So I have a kind of question, but it's more general comment. So don't you think that the best strategy would be to use a combination of biomarker? I don't know, for example, FABP and galactic-3, for example. So did you try this kind of strategy?
Yeah, thank you so much. I think FABP and the galactic-3 is the damage marker as well. So maybe we have to combine the functional markers and damage markers, but maybe we can corroborate with him which biomarkers, or there is additional information of the prognosis itself. So yeah, right now we don't have any data right now, but we have to corroborate. Yeah.
All right. Maybe it's time to move on to the next. Oh, I see another question from Pierre-Louis Tarot. We can hear you, Pierre-Louis.
Thank you very much for your very nice presentation. So no, I was wondering, because I'm naive in the field, but since the protein is coming from tubular epithelial cells, also as the name indicates, I think it may come from the liver. And I was wondering if it's the case, would liver congestion, secondary to heart failure, also impact circulating levels of LFFBP? And that might be, that might be also a reflection of venous renal congestion in that case, liver and venous congestion.
Yeah, maybe, that will happen, but it is in human trials, it's very difficult to differentiate between human liver congestion. So yeah, as you say, if the liver congestion exists, maybe LFAB will increase. Yeah.
That might be interesting to plot the kinetics of transaminase and LFABP in some cases. In acute.
Yeah, that's true. Yes, we have to check the transaminase and LFABP. Yeah, the relationships. Yeah, thank you.
Thank you.
Yeah, very nice point. Now I'm going to turn the chair to Dr. Doi.
Okay.
The fourth speaker. Thank you.
Yeah. Okay. The last speaker will be the Aris Blet, and then the title of presentation is Circulating DPP3, New Hope for Cardiogenic Shock. So please start.
Hi everyone, so my name is Dr. Alice Blet. I'm an intensivist and anesthesiologist in Paris. And I'm very happy to be here today, and thank you so much for the organizer for having me. So today I will speak about the cardiogenic shock, which is the most severe form for acute heart failure. The etiology is for around 5 to 10% of myocardial infarction, and the mortality is really high, with around 40% of mortality for this type of shock. It's the first cause of in-hospital death, and to date there is no treatment which is specific to cardiogenic shock. I will speak about a biomarker we study in the lab, which is called dipeptidyl peptidase 3, which is a cytosolic metallopeptidase, and it's highly conserved among species. The natural non-substrate of DPP3 are angiotensin 2, which, as you all know, is essential for regulation and of heart function and vascular tone, and enkephalin, which is highly relevant for kidney metabolisms. DPP3 also have an antioxidative role via the nuclear translocation of NRF2. In physiology, DPP3 has any hormone is compartmentalized in the cytosol. And in pathophysiology, DPP3 is then translocated in the extracellular compartment where we can measure it, and it's called circulating DPP3. Dr. Degnaud, which did his PhD in our unit, showed that the higher the DPP concentration is, the lower the angiotensin II concentration is. So in green, you have the normal level of DPP3 concentration, and you can see we have a normal angiotensin II concentration. And the higher DPP3 is, the lower angiotensin II concentration. During his PhD, Dr. Degnaud showed that in wild-type mouse, when you do an echo for both kidney and heart at baseline, and then you injected DPP3 or a placebo, and you have like serial echo assessment during the first hours after the injection, it showed the impact of the injection of DPP3 on both kidney and heart function. Here you have the LV shortening fraction represented, and you can see in the purple line, which are the animal receiving DPP3, compared to the dotted line, which is the sham animals. So we have a marked decrease of the LV shortening fraction few minutes after injecting DPP3. So we have a myocardial depression induced by DPP3 protein injection. Likewise, when we study kidney function with the renal resistive index, we showed that after DPP3 injection, we have a worsening of the kidney function with an increase in the renal resistance index 1 hour after DPP3 injection. We then look at the production of oxidative species in the myocardium of these animals, and we can see that we have a higher level of oxidative stress in the myocardium of animal receiving the DPP3 protein. Dr. Tagaki was a Japanese fellow in our lab a few years ago, and together we published this study about DPP3 association level with cardiogenic shock and the occurrence of refractory cardiogenic shock. So it was a cohort of cardiogenic shock patients. On the left part of the slide, you can see the DPP3 concentration at different time points at inclusion in the study, and then 1 day, 2 days, and 3 days after the inclusion. On the box plot in the red are the patients who had a refractory cardiogenic shock, and you can see that they have a higher level of DPP3 compared to the non-refractory cardiogenic shock. Similarly, when we look at the Kaplan-Meier and with the level of DPP3 at admission, we can see that the patient with a high CDPP3 at admission had a high chance of dying during the first 90 days. Then Dr. Degnaud realized this study during also his PhD. It was an ancillary study for CardShock study, which is a cohort of a cardiogenic shock patient. He showed in this study that non-survivors, which are represented in gray, had a higher DPP3 level, either at admission, 12 hours after, and during the first day of ICU admission. We then studied serial measurement of DPP3. So the first measurement was at inclusion, and the second measurement was 24 hours after. What is interesting here to see is that the patient who has either low or high DPP3 at admission, but evolves to have a high DPP3 24 hours after, were the most at risk to die within the 91st day after ICU admission. Likewise, when we look at organ dysfunction, patients who had a high DPP3 24 hours after admission, either starting from high or low at admission, so both high and low high, had a greater need of cardiovascular support, so vasopressor, or have a decline in their kidney function. So DPP3 in this study was associated with a poor outcome regarding mortality or organ dysfunction. We collaborate with a German company who developed a procizumab, which is a specific antibody directed against DPP3, to test this antibody in a preclinical study. So Dr. Degnaud, during his PhD, studied in an acute heart failure model with isoproterenol the impact of procizumab or placebo. So the setting was the same: baseline echo, then inducing acute heart failure, and a therapeutic injection of procizumab, and a follow-up during the first 24 hours. He showed that the LV shortening fraction was well decreased after the induce of the acute heart failure model in both mice receiving isoproterenol. But as you can see, we had a prompt recovery of the LV shortening fraction in the green animals, which are the animals treated by procizumab, and they come back to a level comparable to the sham animals, whereas the animals who received the placebo had a low shortening fraction that sustained. Likewise, we also improve the renal function. So both animals treated with isoproterenol first had an increase in the renal resistive index, and 6 hours after the administration of procizumab, we had an improvement of renal function and renal resistance index in animals treated by procizumab. When we looked at the oxidative stress staining in the myocardium of this animal, animals treated by isoproterenol only had a huge increase of the DHE staining in the myocardium, whereas animals treated by procizumab had levels which were similar to sham animals. So the procizumab here was helping to improve renal and kidney function within few hours. So our hypothesis is, so in physiology, a DPP3 is in the cytosol, and in shock condition like cardiogenic shock, we have an increase of circulating DPP3, which is a myocardial depressant factor and induce myocardial depression. Our hypothesis is with procizumab, which is an antibody directing against circulating DPP3, we can improve cardiac contractility and hopefully improve the outcome of patients with cardiogenic shock. So to conclude, we showed in this study that DPP3 is a myocardial depressant factor. Circulating DPP3 is a novel prognostic biomarker which can both predict refractory cardiogenic shock, organ failure, and outcome in cardiogenic shock patients. We show the inter-associated measurement of circulating DPP3, which can, with other usual parameters, clinical, biological, and metabolic parameters, might help to assess the treatment success of cardiogenic shock and guide escalating therapies such as increasing vasopressor or implement a mechanical device. Also, DPP3 is a promising biotarget. We showed in our preclinical studies that DPP3 has a key role in altered hemodynamics in a mice model, and that is inhibition by procizumab improve cardiac and kidney function. So it's a new hope, hopefully, for cardiogenic shock. Thank you so much for having me, and I'm happy to take any questions.
Thank you very much for your wonderful talk about DPP3 as a possible, causal player for cardiogenic shock. So now this presentation is open for questions. Okay, let me start to ask you one question. This molecule DPP3 will destroy angiotensin II. So you showed some data regarding the blood level of angiotensin II and the level of DPP3. But that means angiotensin II will be a protective factor for cardiogenic shock. My understanding is correct?
So we have to perform other study to understand well the mechanisms of DPP3 regarding angiotensin II. But when we measure angiotensin level in the animals, we show that we have a decrease of angiotensin II when we injected the procizumab, which helps to restore the cardiac function.
Then angiotensin II helps.
So we can say, like, we can hypothesize, yes, like angiotensin II might improve the cardiac contractility in our studies, yeah.
Okay, another question is, you are talking about the data of the cardiogenic shock, but this is mostly caused by ischemic kidney heart disease, I mean the acute coronary syndrome, or other valvular disease such as mitral regurgitation, etc. So what is the main cause of cardiogenic shock? Or did you, include the septic shock patient? Some septic shock patient will develop the sepsis-induced cardiomyopathy together with the reduced ejection fraction due to the severe inflammation. So just please tell me.
Yes, thank you so much for this question. So you're right, there is like multiple etiology of myocardial depression. And I didn't present the study, but we studied also DPP3 impact in septic shock and myocardial depression induced by septic shock. And we found similar results that DPP3 worsen cardiac function, and that when we rescue by procizumab, we have similar results with an improvement of contractility of the heart by procizumab. So we have similar results, so it might have a common pathway among myocardial depression, regardless of the etiology of the shock.
Thank you very much. So another question from Pierre-Louis. Yes, please.
Yes, thank you very much for your nice talk. So I had some related questions. That one would be, could you speculate about the mechanism? You say that DPP3 is a cardioprotective, is a cardiodepressant, sorry. So what would be the mechanism? And second, you show nicely that in experimental models that there is increase in the renal resistive index that can be corrected by DPP3 antagonist. Would you speculate that this is only secondary to improvement of cardiac output, or is there a specific action of DPP3 in the kidney?
That's an excellent question, and actually it's the subject of one of the PhD students in the lab at the present time, because we don't have yet the answer. That's why we decided to study the impact of DPP3 in a cardiorenal syndrome in a preclinical model. So today we cannot answer this question. We see that we have an impact on the kidney and on the heart, but we don't have any mechanism so far to speculate or to hypothesize here.
Thank you.
Okay, thank you very much for your nice presentation. So finally, in the end, we finished for presentation just in time. Yeah, which is very good. So we learned a lot about the kidney-heart interaction regarding a new possible biomarker or newly developed pathways. So I'm very happy to learn a lot about from 4 presentators. Thank you very much. And Chantal, please.
Yeah, I think we had a great session and very lively session of questions and answers. So I would like to congratulate all the speakers for their presentations and the stimulating discussion by the different members of this meeting. So I think, Alex, we will give you the speaker and the microphone, and then you can decide whether or not we go on with the coffee break.
Yeah, I think we need a small coffee break, and I'm so sorry that I cannot send my beautiful French croissant through Japan, because they look great. If you like, later I can show you one of the croissants. But thank you so much for this session. And then if you agree, we reconvene in 15 minutes. In 15 minutes, and then Shiro and myself, we will share the next session. Then we give ourselves 15 minutes to have a coffee. For you, coffee or tea, by the way, maybe. But for us, definitely a coffee. And we reconvene in 15 minutes. Thank you so much.
Thank you.
Thank you, everybody.